Okay. Yes. So I think it's up and running now, entire screen. Let me share. Can you see my screen, Doc?
Yeah, I can see.
Chalo, I don't think anyone else has made it, but we'll not waste time. We will start and proceed with Dr. Shruti's case.
Okay.
So we'll pick it up from where any specific questions that you have had. Unfortunately, I mean let's plan our session one of the days. My voice is still not better, so I don't think I want to wait anymore. We'll plan one of the days, and we'll take up the few
Sure.
queries that you had.
Yeah. Or when I'm there, we can clear that. It's no
Oh,
problem.
we can do that also. So you keep jotting things down. So we'll
Yeah,
take
yeah,
up
yeah. I've got.
everything together.
Yeah. One of the things which little bit confusing for me since we are waiting for that.
Hmm.
Maybe should I ask? Can
Please,
I? Yeah.
please.
That you know that this when we are doing the expansion, when we
Hmm.
are doing expansion, so it's like if we are doing a molar expansion
Hmm.
and we can do the rotation at the same time as expansion, isn't
Yeah.
it? That is in specific cases, I know, but we are placing a bracket, sorry, a attachment on the buccal surface of the tooth to
Correct.
prevent it from tipping.
Yes.
But also I have seen certain videos where online classes and all those things where they said that you have to incorporate some sort of buccal torque
Hmm.
of some two degrees or something when. So I don't know, is how do we incorporate that buccal torque? Is it like when we are doing the on the movements this thing, or we incorporate an extra 2 degrees
See,
buccal torque
see,
or lingual torque, whatever anterior?
let's imagine this molar. All right.
Yeah.
Let's imagine we are planning to expand like this. All
Okay.
right. Now,
Yeah.
you imagine that if you try and do it, unless you have like a rectangular wire and the slot is matching to your wire, the chances of this movement, let me undo this, the chances of this movement is going to replicate like this.
Yeah. So hanging will happen of the
है ना?
yeah,
This is what we are
of the
going to end
palatal
up with
cusp. Yeah.
most of the times in the
Yeah.
process of that expansion process. So
Yeah. Correct.
what we are trying to do is, for example, if you add a rectangular attachment here,
Yeah.
I don't think it's going to allow us to edit this attachment. I think we
Yeah.
subdivided the
No, no,
subset.
we can't. We can't.
Let me see. No, it's not going to let me
Yeah.
edit that.
Maybe we can. The seven we can try.
No, so seven. So ideally, when you're trying this, your seven has to be an anchorage. You
Yeah.
can't take the seven also into expansion, because then you're not going to be able to, you know, uh, give that much traction. So,
Okay.
for example, let me just add one attachment over here, just for the sake of understanding that we plan a horizontal anchor attachment, sort of. So suppose we've added an anchor attachment, too big right now, but just for the
Okay.
sake of understanding, we've added a rectangular attachment, adding a slightly bigger one for better understanding. So imagine like this. Now, now you imagine that molar, when your aligner is giving the push and the natural process is going to be tipping like this because of the push,
Yeah.
because you are applying
Yeah.
forces at the crown level and the center of resistance is at the center, but your forces are here. So when this
Yeah.
tips, this is going to tip like this. Correct?
Yeah.
Now to counter this, what's going to happen is you're trying to not replicate this movement, but you're trying to horizontally translate it buccally. This rectangular attachment, when the natural movement is going to replicate this, that horizontal attachment or anchor attachment over there is going to prevent and maintain that torque, not allowing
Okay.
it to tip like this.
Like, okay.
By maintaining that torque over there and giving a
Okay.
counter force. So this is trying to move like this, but the flat surface over here is going to give a counter force on top of that.
Okay.
Got the idea?
Yeah.
So basically, you're not in your aligner planning, you're not making it hanging at all.
Okay.
And
So in this,
because you have not made it hanging and added a horizontal anchor attachment, now this is trying to maintain its torque, not trying to
okay.
let it hang or move or tip buckily. It's
Okay.
counteracting that force.
Okay.
And in future, when you start doing a couple of cases and you want to add one more, you can add one more vector of force by putting a dimple here.
Okay. Yeah,
So
that is with the, we can do it with the
dimpling plier.
uh, pliers. Yeah.
Yes. Or in if we are going to do it over here, then we might do it with the what do we say? We might do it with the
The
negative
negative,
attachment.
negative attack.
Yes, yes.
I still need to know how to, like, where do we get these negative attachments from?
No, no, we have to add it. So I would tell you that please don't get into that right now. A dimpling
Okay.
plier would give you far more control right now to begin with.
Control. Yeah, that's what you said. You were
Yes.
telling me. Yeah.
And later on, then we can move to that. Last time we had taken the upper, I don't remember which uh, arch we were
Yeah, I
treating.
think
I
we
remember
were
taking
just
the lower actually somehow. So what I'm thinking is, I'm thinking I'll delete this plan and just start fresh. And quickly in like half an hour, no, we'll like try and see actually if you start planning the case, it doesn't take more than 10-15 minutes. So it'll be a good
yeah.
experience that way to see. All right, so phase one, this is our zero position. Okay, nothing we have moved. So let's evaluate. Oh yes, last time we had taken the staging for this premolar and canine, if
Yeah.
you remember.
Yeah, we distalized the
Distalize
premolar.
this premolar.
Premolar.
Okay, so let's take this up again today. So let's move this distally and let's tip this facially. Okay, sorry, I forgot. Okay, slight amount of overcorrection that
Yeah.
I'm planning to do over here. Let's see how is her upper. Sorry, they definitely are
How how much overcorrection do you recommend? Like if it is we are moving
10
0.25
20%,
linear, 10-20%. Okay.
10 20% of whatever you are planning. Okay, so as of now, let's hold this for a second here. Let's now move to upper. So we are planning her phase one right now. So
Yeah.
let's plan this canine. Let's try and distalize this and have some amount of derotation included. Let's try and tip it distally and also derotate and also move it. Okay, so the upper anteriors are actually decently aligned right now.
Yeah.
So we can think that since I'm moving the strongest tooth and the longest tooth, why not? And since it's a dentist and since we are controlling everything, I'm thinking why not, even though I might waste a few aligners, why not keep this anterior as a selective anchorage?
Yeah.
Not do anything, literally anything over here. But this premolar, no, this premolar I want to derotate actually. And even this, in fact, like how we had discussed last time, I'm thinking इसको भी इधर derotate करेंगे. हो रहा है मतलब
Mm.
I'm not getting a lot of constraint over here. Let's derotate these two premolars so that the molars are still anchorage. The canines are sort of tipping distally and simultaneously derotating and translating distally.
Okay.
Now, this plastic coverage that we are going to have of this canine, no, is going
Yeah.
to allow us to maintain its torque. So for this movement to happen, we need to have a nice, strong rectangular, attachment over here. So let's
So
try
horizontal.
have no vertical. You want to maintain the
Vertical,
torque
sorry. Vertical,
ha,
vertical.
for
Sorry.
horizontal movement.
Yeah, we are moving sideways. Yeah. And yeah.
So since the doctor already has an attachment, I'm trying to engulf that whole attachment also, so that we don't have to call her again for debonding and stuff like that. Adding a little over the board, little thicker attachment for this canine. Okay, now to counter this, I want an anchor here. So this premolar we are derotating, right? So it is
It should be
derotating
vertical.
mesially. So I
Oh,
want
you
to
are
have
giving.
this slightly towards the distal. You were saying something, Doc?
No, I thought because we are rotating, we will be placing a, and there is also some distal movement on this. No, we are not,
Little bit, not really. See,
not much.
in fact, it's mesially derotating. Now, this right now has an attachment, so I'm not going to disturb that, and let's preserve that right now. Sorry. More flat surface, okay, to have better control. Same thing over here on this canine. Now that old attachment, no, is like really huge if you notice over here.
Yeah.
It's too much. I mean, my attachment is too much. Okay, let's make it a little longer. Okay, let's preserve this. We have our flat surface and we'll utilize the surface of the existing attachment also. So ideal would have been either, we would have just debonded all the old attachment and just, added new fresh ones. So, but that's okay. We can do that maybe in our next phase also for once.
Okay.
So we'll
Doc,
continue
these are
using.
not like these are not the normal attachments you're using, isn't it? This
I'm
is not
using a
what is there in
rectangular beveled. Yeah, I'm using a
level.
rectangular build. I'll help you out with this attachment.
Yeah.
Lovely attachment. 90% of my all my movements I am able to do just with this. No fancy other attachments to be added. Lovely attachment. ज्यादा क्या बोलते हैं कॉम्प्लिकेशन ही नहीं.
हाँ,
Now,
ये
I'm not
अच्छा
going to
है.
add any attachment on this premolar because this premolar is going to act as a good anchor because of the
Encourage, yeah.
space in between plus and existing. Of course, this kind of attachment is of no use. What you see over here, such a rounded attachment has no flat surface, no engaging happening anywhere. So we're going to stop here. As we've always discussed, lateral incisor is something that you should never miss an opportunity to add an attachment to. So since you are not making any movement right now, as of now, let's add a small anchor attachment on the lateral. Okay. So, and if you notice, we've added it slightly more incisively
Okay.
because the strength of the
What?
aligner is better at the incisive.
But more incisal. Yeah, it is thicker.
Yes. Okay. Let's see how many aligners is it showing. 0.25, 18 aligners. Just for this canine to move. Ouch. So let's see, let's come down to the lower and then we'll evaluate that do we really want to spend 18 aligners and not touch the anterior segment of it. So oops, delete, let's go to movements. Let's start aligning the lower anterior. Sorry. Let's have this lateral, I mean, this lateral incisor. Let's have it distal out like this.
Yeah. So
So,
here
and
both sides you will get the vertical, uh, horizontal
no,
attachment.
I
Both
don't
sides.
want to, especially since the patient is also a dentist. I wouldn't want to, I don't want to have this movement. Let's have this slightly tipped also. Okay, we'll do some IPR and keep an eye on this. Basically, I am right now doing a little bit of round tripping sort of this thing right now, where I'm flaring it a
Okay.
little bit so that we are able to correct the crowding with least amount of IPR in between.
So, dog, that we need to check the midline with the upper, isn't it? To see, should we do we
So
do that?
honestly, looking at this case no, right now, that we would be managing, I feel, when we are actually moving the uppers,
Yeah,
getting my point. So, which I feel we will, because I
yeah,
don't see any sense of not utilizing 18 aligners for some retraction of the uppers also.
yeah. Can combine the.
Yeah. See, but I don't think we have space. See, unless because we don't have any space to utilize here unless we try and utilize this. But then if we try and utilize, then we are not going to definitely end up with uh, matching midlines.
Yeah.
Definitely going to shift the lower if we try and utilize this space as much as possible. So instead of flaring up now, I'm going to resort to more IPR because for the upper correction, we don't have space.
So basically, you're doing the IPR and retroclining the lower in size.
Yeah, I mean, we don't have a choice, no? Because closure of diastema is the patient's chief complaint. And this canine is moving. Yeah, it's moving quite a bit. So let's move this, let's overcorrect the movement of this premolar now. But this type of attachment is not enough. This happens when
Yeah.
flowable is used. In my experience,
So
when your attachments turn out to be like this, shapeless, but still some blobs of something, it's because the composite that was used, no, is not that great.
yeah, I think
See,
it is
because it's
like, is it the composite has degraded, or I mean, like it has faded off, isn't it?
yeah, yeah, yeah. I mean, most often that is what I've always seen happening.
So, doc, that canine, when you move that, when you are giving your first before that, do you do some stripping there, like just to relieve the?
Once we get a rough plan, no, doc, I'll show you. How do we go about planning the IPR also? How will you think that do I strip when I strip everything? Okay, I'm ending with like 0.5 millimeters of IPR almost everywhere. Okay, and a deliberate diastema over here because I don't want that when this canine is actually trying to cover so much distance, you know, at that point of time there is any interference. Okay, I've got a 10-minute countdown timer right now. Okay, from Zoom. So we'll try and see. So this, if you notice, when this canine is undergoing this movement like this, so it's sort of also intruding and flaring forward downward. So to facilitate that movement, I want to do two things. I want to remove all the constraints that would be there, and as an attachment, no, I would want to put a horizontal attachment for this,
Yeah,
not a vertical one, because according to me, when that movement will get replicated, it will be like a vertical movement. It will be like a forward downward movement for that canine. So let's have a nice horizontal attachment for this. It'll engage that canine very, very well, and it will make sure that it will not allow, any tracking loss to happen if I am able to maintain free movement for that canine. Only thing I want to check is it going to hit the upper when, let's go to default. Nah, enough space, है ना? We have enough
Yeah.
space. So it's not going to hit the upper canine. That's for sure. When the patient is eating, of course, after removing the aligners. So this part is sorted. This premolar needs to get a vertical attachment.
So, won't we put a vertical attachment on the for 3-2 also?
3-2 also. No? Yeah.
Yeah, because we are.
It would be a good anchor,
Yeah.
The problem being, or I can move it completely out of, that old attachment.
Mm.
Maybe that's something I can do. So the best part about this journey, and the reason why it's not meant for everyone, because whoever is getting into this journey needs to have like an experiment or a mindset of experiment. What I mean by that is that you need to have that mindset that, okay, sometimes you're successful, sometimes you're not. But when you're not, even that is actually good data. For
Yeah,
example,
that is the
I have
best.
learned
That
my
is the best.
lesson
That
that,
is the best.
okay, existing attachment not done by us, no, we will not accept. It has to go. If it's done by us, I will preserve. But if it's not done by me, I will tell the patient that no, I will remove all of them and only then do.
Yeah.
So there is some blob of composite here also. Unfortunately, I'm going to decide whether to keep that. No, doesn't mean anything. Let's add one more anchor here.
So that is like we can do a horizontal. Yeah.
Yeah, horizontal anchor. No
Nothing.
fuss over
Just
there.
first because
Just
we
an
are not
anchor
bold.
attachment. Yeah, it's sort of covering the old attachment also, which is also good. Just an anchor. That's it. Okay, now let's figure out this incisor. Let's see how much movement is it making. Yeah, it's making a decent amount of vertical movement. So why not have a vertical attachment? But I think that tooth already has a vertical attachment. So I want to show
Yeah,
you
it's already.
something here. Have a look at this. A lot of times, no, when you don't see clarity, you can go to show scanner acquired texture. See, it's more clear now than a real color. So see,
Yeah,
there is
correct.
already enough of, attachment over here for such a small
Yeah.
incisor. So as of
Yeah.
now, for this phase, I'm thinking I'm not going to do anything. I'm going to leave it. Let this attachment get utilized. Okay, let's see what other movements are other teeth making. This also has an attachment. The rest of them do not have an attachment. So I'm thinking I will let go of one and add on one. What I mean by that is, let's add one attachment on one of these teeth, either this or this. This has a bigger root surface. Let's add on this. The rectangular beveled, no, you don't need to give a lot of gingival beveling. So you can have very,
Ah,
very strong surfaces, you know, helping you out rather than a pure rectangular attachment. It's very rounded, very easy for the patient to remove. Fantastic attachment.
I got this from some a website called Three Culture.
Three
Both,
cult.
but
No, the
yeah, but it's
orientation you
not.
won't get.
हाँ ओरिएंटेशन नहीं है इसका वो XYZ एक्सेस
Ah.
पे ओरिएंटेशन
Now, on this 7, I know it's hard, but I want to add a small anchor attachment on 7 because I've noticed, no, it starts lifting from the terminal tooth. If you don't have one attachment on either the 6 or the 7, it lifts up, and the patient doesn't
yeah
like it then. So, a
correct
tiny one just to make sure that the aligner seats perfectly. A small one more mesially so that it's easier to bond. Okay, we have 2 minutes. I want to show you something. How am I going to calculate the IPR thing? Now, see, it's moving. Keep an eye on the intersection or IPR values that are going to come. Something is not right. We've not subdivided the setup.
yeah.
Okay, that's 18. What are we doing in the upper?
So we just rotated the premolars and then we moved them distally.
So I want to also see that whether, oh, I have a lot of place here. Let's fix this. Let's derotate and let's tip it palatally. This is the max I think we would tip it for her, I feel. We're already too upright. Hana? What do you think?
Yeah it's
But without that, no, it's difficult for us to. Less than 1 minute, the meeting will end. I'm going to resend a new meeting link.
okay then.
Nah, unless we intrude, we're not going to get to do this movement.